Hi friends, he is a 38-year-old male presented with dense cataract, slightly overweight. In these patients where obesity is the problem, during Phaco, the biggest problem comes is the positive pressure. So here, if you have started your Phaco, it's always good to give some peribulbar block, or if you are an experienced surgeon, you can plan under topical. The tunnel length should be proper because our chances of prolapse of iris, the chamber should be maintained properly because these patients have problem in breathing. So your tunnel should be more than 1.5 mm in length. You can use any width 2.8 or 2.2 mm as per your convenience. As the age is 38 years, we expect nucleus to be soft. There is no history of any steroid intake, very slight hypertensive, no diabetes, one eye dense PSC, other eye was normal. We are using Visco. Before that, we injected phenocaine to avoid any discomfort to the patient because that will increase their anxiety, that is stretching of the iris. So you should try to finish the case within a short time and should plan your steps before starting the surgery. Now we are doing Capsulorhexis. Our aim is to have a 5 mm rhexis. As I have taken the case on the topical, one thing I will show you. If the patient moves the eye, you should lift your capsulotome. Otherwise, there will be abrupt tear of the rhexis. So when you are doing rhexis under topical, you should take care. First of all, the patient should be explained that they have to look straight towards the light, and this is a very important step going on. And if they move their eye, just lift the capsulotome little bit so that there is no damage to the capsule. Here, if you make a bigger rhexis, there are chances when you finish the case because of the positive pressure, the lens will come again and again up from the back, and positioning of the lens inside the bag will be difficult. Now it's time to do hydrodissection and delineation. Here we have planned the prolapse of the nucleus into the AC as the cataract seems to be very soft. As you can see, the nucleus is delineated, a golden ring is seen, one edge is lifted, multiple section hydrodissection and delineation is done. Visco is pushed above the nucleus to save the endothelium and also in the back to lift the nucleus vertically. Again, Visco is pushed above the nucleus to protect the endothelium. Now, just prolapsing the nucleus into the AC to make the nuclear emulsification easy with Phaco 2. With the help of the dialer holding the eye, entering into the eye with the Phaco probe under Phaco 2. Here the vacuum is 380, power is 50 as the cataract is soft and flow rate is 40. The nucleus is emulsified in the safe zone, the central part of the eye. Now we have a chunk of epinucleus and cortex that seems to be very soft. I am trying to pull it with lower vacuum under Phaco 3. Here the vacuum is 250, power is 30, flow rate is 25. But the patient is having anxiety and breathing heavily. So I decided to do the epinucleus and cortical removal with the help of coaxial IA because that will be more safer There I will apply a higher vacuum. Normally I use 400. In this case I will use 425. Some hydro dissection is repeated to separate the cortex and epinucleus from the bag. Here you should be careful that your cannula should not touch the posterior capsule, and patient movement should be taken care because sudden movement, jerky movement can cause touching of the cannula probe to the posterior capsule and can cause PC rent. Now with the help of the coaxial IA, aspirating the remaining epinucleus and cortex. Whenever you rotate the tip of your coaxial downwards, that hole that goes downwards, you have to take care that you should be slow and steady because a sudden aspiration of the cortex can cause the catch of posterior capsule. So you should be careful. When the tip is upward, it's not a problem. Now we have some cortical fibers remaining. So we shifted to IA2 where the vacuum is 200 and flow rate is 25. Pulling the cortical fibers towards the center and aspirating. The posterior capsule is bulging upwards. Some fibers attached to the posterior capsule. Very carefully, under low vacuum, we will aspirate these fibers. Mild posterior capsular polishing is done to release that small part of cortex and aspirate it. Now it's time to implant the lens. Here we have plant Hoya Impress, an advanced monofocal lens. Having a multi-site injector. The lens is dialed into the bag. Now it's time to do the visco wash from the AC with the help of the coaxial IA. Visco wash should be given time. Proper visco wash should be done from all the angles. Here I am not going behind the lens, just taping over the lens to remove the visco behind the lens, as there is a bulge in the posterior capsule because of the heavy breathing by the patient, and because of his weight he is not comfortable lying on the OT table. We have taken care that head end of the table is little bit 10-15 degrees up from the fit level, and our anesthetist is there on the standby. AC wash is completed. We'll do some lavage with the BSS. Now it's time to hydrate the wound. First, I always hydrate the main wound, both sides. Here we have to hydrate little bit more to counter the positive pressure. If you feel that the chamber is not forming even after hydration, you can always put one suture for the safety, or one thing you can do is you can put a small air bubble and explain the patient that vision will be blurred for 1 or 2 days, or you can patch the patient also. The case is finished. Thanks for watching.